So we are live now.
Hello and a very good evening to all. I, Dr. Dhammadeep Dabade, on behalf of Emcure Pharmaceuticals Limited, welcome you all on the occasion of No Thrombosis. No Thrombosis is an unique scientific initiative by the Emcure, which has been awarded recently by SIMS as a healthcare excellence by any pharma company in India. So this program basically is to discuss and understand about various thromboembolic situations which are based upon the real life challenging cases. The various cases can be pertaining to either CAD, PAD, DVT, pulmonary embolism, AF, or coagulopathies. So with the help of various real life challenging cases, we will try to learn and understand about the effective management strategies, more specifically in those situations. So in this program, we will be having the esteemed faculty with us today. The course director for our today's session will be Dr. Girish Nosundi sir. I would like to introduce Dr. Girish Nosundi sir, who is the Director, Cath Lab and Senior Interventional Cardiologist at Apollo Hospital, Bangalore. And sir has the vast experience in the field of cardiology and been done with many interventional procedures. And sir has presented numerous research papers and written several articles in the various journals. Our moderator for this particular event is Dr. A. George Koshisa, who is the senior consultant cardiologist affiliated with the Cosmopolitan Hospital, Trivandrum. Sir being the former professor and HOD of cardiology department at GMC Trivandrum, and also the former director of Kerala Heart Foundation and honorary cardiologist to Governor of Kerala. Then I would like to introduce about our next moderator for this event, Dr. J. Kannan sir, who is the senior consultant interventional cardiologist affiliated with the Narayana Hrudayalaya, Bangalore. He is working in the field of cardiology since more than 20 years of time, and he been the member of prestigious Pediatric Cardiac Society of India and also the CSI. Now I would like to introduce about our speaker who will be presenting his real life case, Dr. Sarthak Sahu. Dr. Sarthak is the in charge of critical cardiac care unit at Narayana Institute of Cardiac Sciences, Bangalore, and been presently as the treasurer of IAE Karnataka chapter and also one of the organizing committee members of IAE National Conference. Been published with several articles in various national journals. Our next speaker will be Dr. Sravan, who is the vascular and endovascular surgeon in Trinity Central Hospital and Sri Jayadeva Institute of Cardiovascular Sciences and Research at Bangalore. Been trained in vascular and endovascular surgery at Jain Institute of Vascular Sciences, and also later got fellowship at the National University Hospital, Singapore. So with that brief introduction, I would like to just go through today's agenda of this event. We'll be having the opening remarks from our course director and the moderators before going to the actual case presentations. Then we will be having the two cases one by one. Each case presentation will be followed by a brief discussion amongst the course director and the moderators. So with that note, I would like to stop here and would like to straight away hand it over to our course director, Dr. Girish. Over to Dr. Girish. Thank you.
Dr. Dhammadeep and Mr. Kesur from Emcure, it's always my pleasure. From day one of this program, we've been actively involved in the discussions, and it has always enriched me. Thrombosis is such a dynamic process. It has been constantly challenging physicians, be it cardiologists, be it vascular surgeons, or be it neurologists, or even physicians who deal with myocardial infarction, pulmonary embolism, or strokes. in the backdrop of COVID, it has become more enigmatic, and the presentations have been much more varied and complex. And Emcure has made an effort all the time to bring a variety of presentation of same thrombosis and bring in that crux of knowing thrombosis, which will help you to prevent and treat thrombosis very appropriately. So towards this, I'm sure we'll have two more very interesting case presentations. And as usual, Dr. Koshi, who's been my co-chairman or director, who has always brought in great inputs and understanding from his side. And Dr. Kannan has joined us recently and has been a great addition in understanding and having discourses on this. So with these opening remarks, I forward it to my colleague to start their presentations.
I think we can start with Dr. Shravan, sir. I think. Yeah.
Dr. Shravan,
can you
good to go?
Yes, I'm good to go, sir.
Thank you.
I'll just share my screen. Is my screen visible?
Yes, sir. Yes, sir.
Yes.
Good evening, everybody. A very big thanks to the Emcure team to getting me involved in this no thrombosis workshop. And it is a pleasure to present to senior teachers like Girish sir, Koshi sir, and Kannan sir. I am Dr. Shravan. I'm a vascular surgeon, assistant professor in Jayadeva Hospital, and I practice in Trinity Central Hospital. And I'm presenting a case of popliteal and tibial recanalization. So being a vascular surgeon, it's given me the opportunity to treat the entire vascular bed from head to toe. This is just an example of the list of conditions which I can touch upon. Of course, the heart is always there to Girish sir and Koshi sir and Kannan sir. And of course, we take the help for a lot of the aortic disorders as well. So at this presentation, I would like to go right down to the foot, where this patient had classic PID symptoms of gangrene. And as the saying goes, the foot is the mirror of the body. And this patient was no less. And I would say that any complex CTO cases is like Tom Cruise's stunts. It looks very complex. It's very difficult to do. We wonder how he gets it done. But with careful planning and changing the strategy as the time goes would help us to get through the difficulties and in the end get an awesome result. So my patient was a 70-year-old male. He was a community ambulant person, ex-smoker, diabetic and hypertensive, known coronary disease, had his LAD stented 5 years back, but very bad heart with poor ejection fraction of 25% and repeated admissions for cardiac failure. He hurt his toes while trying to cut the nails, and this gradually turned into non-healing areas and changed into gangrenous. So he had almost all the toes with multiple gangrenous changes, and gradually the first toe dorsum turned into a mildly infectious patch. The worst was his rest pain. He had absolutely no sleep. And when he came to my outpatient department, he was literally pleading to chop off his leg. So as all the clinical features were classical and the wound was classical of a PID, I went ahead and got a CT angiogram done, and the right side is the index limb. Of course, the iliacs and the aorta and the SFA is okay, but there's a CTO in the right popliteal. And in the infrapopliteal segment, you can see that the posterior tibia is completely knocked off. Only the plantars are reformed. Peroneal looks good. TPT again looks bad. And the anterior tibial, there are just patches seen. And of course, with the calcium, it's very difficult to assess whether it's open or not. But again, the flow has been seen from the dorsalis pedis. So I took an antegrade approach. Punctured is the right common femoral under ultrasound guidance. And just like how the CT showed, this is the first diagnostic check angiogram. CTO with a sudden short stop and a large collateral coming down, reforming the peroneals. And the beautiful part is that the collaterals are very good. So I took an 035 Tiramo, trying to go down with a knuckle and a 5 French MPA catheter. Initially, my target was to go through the anterior tibial because I can get an inline flow to the foot. Sorry about that. Yeah. So this is my shot of the anterior tibial, almost not seen at all. But still, I thought, okay, why not? Let's try to get an inline flow. But the wire just couldn't pass. I thought, okay, let's get some pushability and first dilated the popliteal segment with a 460 balloon. And then I was able to push in the balloon into the anterior tibial, again dilated the distal popliteal and the ostial region of the anterior tibial. And with that, try to push in the wire more. But this is the initial check angio, just a trickle of flow in the plastid areas. Of course, we don't have a good outflow right now. But the issue was whatever I tried to do, the wire just wouldn't pass through. I'm sorry, what is? So I decided to do a retrograde puncture of the peroneal artery. I, of course, did scan the dorsalis pedis and the posterior tibial because that would be my initial choice. But there was a clear stop sign, which there's a circumferential calcium in both the dorsalis pedis and the posterior tibial, which would not allow me to get a clear puncture into the artery. And in fact, I may ruin the good outflow. So under fluoroscopic guidance, I punctured the peroneal artery with my ever-dependent staff giving a shot from the top. And as the contrast coming down, I just redirected my needle position. And once I got a good flow, I sent in initially a command 014 wire. We know that the mid and a part of the proximal peroneal looks good. Now, once I put it upstairs just to check whether I am in the lumen, I took another shot. And that clearly shows that I am in the lumen. So then I switched, the 014 command couldn't pass through, and that 1 centimeter of artery in the tibioperoneal trunk was the challenge in the entire case. So I'm trying to push a command, didn't go through. Then I took a V18 wire, which is a 018 platform from Boston, supported with a CXI 018 catheter from Cook. Both are part of my standard retrograde approaches. And I poke, trying to do with a knuckle also, but the wire just couldn't cross that short 1 centimeter. Now, by this time, even though the slides are just flown by, it was already 2 hours. I rechecked how much I've gone through from the CXI catheter. I'm in a good lumen. The peroneal looks good. So I'm trying to pass from above and down. Of course, the angiogram is a 2D view. It shows that we are in the lumen, but it was just subintimal from both sides and not meeting into the true lumen at all. That's my V18 trying to poke through. It looks as if it is near the 5 French MPA, but it's just subintimal. So then I decided to do cart, reverse cart, all that. Took a 2 mm balloon one side and a 1.5 in the other side. Plastid both segments, trying to break through the plaque in between so that my wire can pass through. But again, the wire couldn't go. So then I tried one of my consultants who used to do this in Singapore. So he used to keep a wire from below and an inflated balloon above. So once you know that the balloon bursts and the wire enters into the balloon, you know that you have entered the true lumen. But unfortunately for this case, again, this technique couldn't work, even though the tip of the wire seems to be tickling into the balloon, but still it couldn't pierce through the intima and into the balloon. But there was a small giveaway from the proximal side, so I could able to push that 1.5 balloon from above. And you could see that small cap near the wire from the top, which is the small segment which I've gained by doing that additional card. So I reballooned that portion, hoping to open up the plaque in that region. So giving a decent overlap and trying to break the plaque across. But this was again not helping. This was the shot which almost made me feel, okay, it's time to stop, come back, maybe the next day, try again. At least the popliteal was open, and the main collateral from the popliteal, which is keeping the peroneal alive, that was still working. But then I said, okay, let's give it a last try. Took another V18 from top. And yes, finally, after 3.5 hours of long procedure, I was able to pass through from top. You can see the wire from the top supported by the balloon coming down across the TPT and peroneal and hugging the wire in the peroneal from bottom. So I pushed in my balloon, checked my position, all happy faces across the cath lab that we're into the peroneal. Then took the 4 balloon again. You could see that tight waist at the TPT, the chunk of calcium which was just opening up now. Just took a check shot to see how things are looking. The flow is of course quite slow because we have some dissections in the popliteal and that big chunk of calcium in the tibioperoneal trunk. So at least we have some kind of flow across the peroneal. I know I can work with this. So moving forward, my first thing was to take out that retrograde axis. I passed in a 3 mm balloon down to my peroneal and then inflated the balloon for 3 minutes with mild external compression so that I get good hemostasis at the peroneal, because it's notorious for hemostasis compared to the other retrograde approaches. So once that was done, again took a shot just to see, because by this time it is very clear that we have to stent this segment. So I took a shot to measure and to see my proximal and distal targets on where I should reach. A clear spiral dissection is also being seen in the popliteal. So that chunk of calcium in the tibioperoneal trunk, I had to replasty it. The previous angio showed a very clear tight stenosis, so I replastied with a 4 mm balloon again. And then decided to put in a supera stent. So preparing the bed for the supera stent, I took in a 6 balloon, dilated it quite well from the popliteal bifurcation region till the start of the CTO. And this is the angiogram before I started my supera. So the TPT area where that calcium was not allowing the flow does look decent right now. So dropped in a 5.5 into 150 mm supera. And post supera deployment, of course, the popliteal flow was good, but still that complete contrast washout, which goes down rapidly, is not there. Again, you can see there is some kind of narrowing and recoil at the tibioperoneal trunk region. So I decided to put in regulating stent Of course, we didn't have, I didn't have a long one. So the first for the peroneal region, I put a 2.75 into 38 Promus Premier drug-relating stent. And then with a good overlap proximally and distally in the tibioperoneal trunk region, I deployed a 3 millimeter into 38 Promus Premier. At the proximal edge of the stent, I flared it up a bit. And then this is the final check angio. Good rapid flow going down in the popliteal, TPT peroneal all the way down. And that good collateral giving rise to the posterior tibial without any contrast being left in the peroneal. And this is the final check angio in the foot showing that rapid flow from the plantar down to the plantar arch and to the forefoot where all his wounds were. This was the sound after the Doppler sounds. You can see fantastic biphasic posterior tibial sounds. And this is day 3. Good biphasic peroneal sounds and good biphasic posterior tibial sounds were maintained. Post-procedure, I put him on 75 milligram of clopidogrel, 20 milligram of rivaroxaban. Given the outflow and the disease festival, I wanted to fully anticoagulate him, and 40 milligram of atorvastatin. And this procedure was done in November, and right now the wounds are almost healed. Thank you.
Shravan,
Yes.
let me congratulate you. It's fantastic. I'm somebody who does the CTOs on a regular basis on coronary, and it was so similar. But you just have the privilege, in case if it perforates, if it leaks, you can always open up, which is not possible in our case.
Yes, sir. Yes, sir.
What is important to understand is that perseverance to establish the flow, trying multiple techniques. You tried antigrade, knuckle, retrograde, cart, reverse cart. I think what is important is to have a time frame for each of these technique that you would try, set a time limit,
Yes.
Run it through in your head and tell your technicians that once I cross this time, please remind me so that I can switch to the plan B or plan C or plan D, whatever.
Yes, sir.
The reason is, the more and more you would do this, you will know that time is of great essence, because you would succeed more often if you switch in time than, hanging on with the same thing which is not rewarding you.
Yes.
The second thing is, I think DEBs are an option, especially in a smaller vessels.
Yes, sir.
Because once we commit with stents, if there's a restenosis,
Yeah.
I mean, he's doomed. The same happens with the coronaries. I'm not an expert in the peripheral vascular, but still I would believe that.
Yes, sir.
I don't mind doing another CTO with a DEB in a distal vessel than
Yes,
put in a stent and then leave the patient with no option.
Yes.
But I think the science of vascular science is greatly advancing. Now we have excimer lasers, you have IVL catheters. I think it's important to have long-term goal side by side, the immediate goal of achieving the flow and healing the wound.
Yes, sir.
You greatly saved a limb. Nothing can be greater than saving a limb. Otherwise, it greatly compromises the quality, as well as it's pretty difficult for a man to live without it.
Yes, sir.
And I should really congratulate you for bringing on this case. But why did you choose this anticoagulation? Can we understand that?
Yes, sir. Usually when we have this indirect kind of flow, and of course, very badly diseased vessels, I tend to put on full dose anticoagulation, sir. Of course, before we have lesser economical alternatives now. Previously, it was not in reach of most of the people because of the cost itself. And I used to start on acetylene or warfarin only. But now having this option, I tend to put either on rivaroxaban or dabigatran. But for this patient, again, dabigatran and coronary does have a link. There's a link of coronary events for patients on dabigatran. So I chose to go for rivaroxaban. Again, I wanted to go full dose for him. At least I put complex cases like this, at least for the initial month or two, I tend to put on full dose. And then I step down to dual antiplatelets with 2.5 milligram, that primary prevention dose, which is available now.
I think excellent. Right way of thinking. Maybe you could have used dual antiplatelet and full dose anticoagulation for about a month if the risk of bleeding is not too high. Then you really give them the full benefit. But if there's a risk involved in terms of bleeding, I think what you've chosen, one antiplatelet and one anticoagulation in full dose, and rivaroxaban being once a day also adds that additional comfort of knowing that patient missing a dose would be much lesser.
Yes, sir. Yes, sir. The DAB part, sir, it did come to my mind, but there was a meta-analysis around a year back from a Greek surgeon, which actually started a storm in the DAB segment with a lot of even dissociative vascular surgery and a lot of, I think, the cardiac surgery institutions also coming and telling that within a year their mortalities were high. I don't know how they came to that kind of thing. Most of the people tell it's statistical kind of workup which can be done. So that was one thing. Plus to a long segment DEB, again 2-3 DEBs has to be used for this. So that's why I thought, okay, might as well go in for a stent. And fortunately, the coronary stents are cheaper than my peripheral stents nowadays, sir. Yes, sir. So that's why I went for that option, sir.
I fully agree today, and we also have become very confident to treat an ISR in-stent restenosis with multiple therapies. And there are so many hardwares available, so it's not as bad the scenario as it used to be. But you know, for you also, bypass is an option. But once we put in a metal stent, the bypass is out of equation. So I would still tell patient that it is still worth it. I don't want to close your future option for an immediate gain and saving some money. You know, the dissected lesion, when you want to do a CTO, I think it's very, very important not to extend the dissections for too long. I think that is where we try to set a timeline. If I cannot, subintimal course is good enough. Maybe for 10, 20 millimeters or 30 millimeters, not more than that. Because longer the subintimal and re-entry that happens, the higher the chance of restenosis, reclosures, and lesser TIMI flows. That's why switching strategies, if we don't succeed in about 10, 20 millimeters of re-entry, greatly enhances the chance of not increasing the dissection. And 20 millimeter stent is acceptable, but if you really need to take in very long stents, I think, great immediate results, but we're always concerned on long term.
Yes, sir.
Thank you. It's a wonderful case. And Dr. Kannan, your comments on that.
First, I thank Dr. Shravan for having presented such a wonderful, complicated, tough case.
Thank you, sir.
I would like you to enlighten me on certain things.
Yes, sir.
As a cardiologist, because I'm not much exposed to peripheral interventions, how comfortable are you in putting stents across the knee joint, backside of the knee joint?
Yes, sir.
Doesn't the stent get deformed with each flexion of the leg? And what is the long-term patency in these stents? Whenever you put a stent across a joint,
yes, sir,
doesn't it get deformed?
Yes, sir. So, of course, it is a no stent zone. Similar to the common femoral artery, the popliteal artery is also a no stent zone. But we have only one stent, which is the Supera stent, which is a nitinol woven stent instead of the classic laser cut stents. And that is the only accepted stent to put across the popliteal, sir. Because even if you give a flexion of around 70 to 80 degrees, the artery doesn't get deformed a lot. So if at all we have to go to a stent for the popliteal artery, Supera is the one and only go-to. And of course, the Supera stent is not easy to deploy. It is very difficult to deploy because of its mechanism of deployment. And it has a tendency to elongate a lot. more than the regular self-expanding stents. So the accepted is a less than 10% elongation, and with that, at least the papers show that there's a 90% patency in 1 year. As the elongation increases from 10 to 20%, it drops down to 80%. More than 20%, it drops down to 70% a year. But it is accepted to deploy only Supera across the popliteal artery, sir.
Okay. Thank you very much.
Thank you.
Good.
Thank you,
I think we
Dr.
can move to the next
Shravan. I
Thank
think
you,
we
Dr.
can,
Shravananda.
Thank you,
we
sir.
can go to the next case.
Dr. Sarthak, please, can you just start with your presentation? I request Dr. Sarthak.
Hello. Good evening, everybody, and thank you, sirs, for kindly allowing me to present this case. Am I audible?
Yes, sir. Yes, sir.
Yes,
You're audible, sir.
You're,
Yes, sir.
you're,
You're audible, sir. Yeah.
Many thanks to Dr. Girish sir, to Dr. George Koshi sir, and to Dr. Kannan sir for giving me a chance and present something which is a daily life experience, which is something that me and my colleagues, my friends, we have experienced recently in our CCU area. First, a little bit about me. I am Dr. Sarthak Sahu. I am in charge of the critical cardiac care unit in Narayana Hrudayalaya, Bangalore. And this is something that we came across hardly 11-12 days ago. This was a 64-year-old gentleman, and so this was a 64-year-old gentleman who had a history of diabetes, hypertension, and he came to our OPD for a consultation with one of our cardiologists, and he came for, as far as the patient was concerned, he came for a routine evaluation to our OPD. And when he came to the OPD, he gave a history of dyspnea, he gave a history of some fever, and because he had dyspnea, he came to our cardiology OPD. On evaluating him, the consultant cardiologist thought that it would be better if the patient is taken to the triage for further evaluation, given that we are facing a COVID pandemic, and this might be a case where the patient has got COVID. So after coming to the triage, we took a detailed history and did a follow-up examination, evaluation of the patient, wherein the patient had a blood pressure of 110/60. His heart rate was around 104 beats per minute. The patient gave a history of fever for more than 4 weeks, low-grade fever on and off. And this patient, when we did the ECG showed sinus tachycardia without any other abnormal features. Echo showed on a good biventricular function, no dilatation of any of the chambers. The only thing of note that we saw is that the IVC is appearing to be a little underfilled. We thought it could be subjective, and we went ahead with the blood work and chest X-ray. The chest X-ray was normal. Blood work showed a mildly elevated total lymphocyte count around 13,000 odd, with some neutrophilia, lymphophilia. Platelet counts were slightly above normal, around 6 lakhs units. D-dimer we had sent as part of our routine workup, which was somewhat elevated, near about 1.2. So when we reassessed and took a further detailed history of the patient also said that he has been traveling by car and he had come to our center with some leg pain also, and which further revealed that the patient had a long distance travel around 14 hours 4 days back. We were pretty sure by this time that the patient doesn't have COVID. RT-PCR test done at our center confirmed our doubts, and we also determined when we did a bilateral lower limb venous Doppler and the arterial Doppler, the patient showed right lower limb femoral pain DVT. So now the interesting part for us was that initial workup, the patient was having dyspnea, the patient was having fever, the patient was having some leg pain, which was mild, and the patient was giving a mixed picture. But overall result, when we found out that the patient is having DVT and the blood work was a little abnormal, we took a hematology consultation, and further follow-up and work is happening in the hematology department where the patient is further admitted. And this patient probably has lymphoma. They are not yet sure. They are doing the workup and will reveal to us very soon in the future. Treatment that we started initially was low molecular weight heparin, which was weight-based. And then we switched over to oral anticoagulant since we wanted to discharge the patient from our side. And the patient was initially started on rivaroxaban, a full dose anticoagulant. Initially started on BD dosage and then switched over to 20 mg OD rivaroxaban.
Thank you. Thank you, Dr. Saab. So, Dr. Saab,
yes, sir.
If you have to summarize, what made you choose this way?
Yes, sir. So the initial presentation of the patient was quite confusing because he is having fever, he is having some dyspnea, and he is coming to the OPD with all of these symptoms, which initially could go either ways. But once we started the workup, we realized that we are definitely not looking at a COVID picture, and the patient is volume underfilled. So the first instance where we started thinking that something could be going wrong, and when we particularly did the echo, the IVC is appearing underfilled, and the patient also appears a little dehydrated. That's what started us thinking that there is more to the story. So when we took a further detailed history of the patient, we realized that yes, there is also a history of long distance travel. So we might be having this probably a pulmonary embolism or deep vein thrombosis, something of the sort. X-ray ruled out massive pulmonary embolism. Definitely, it is not there. And since we got the DVT diagnosis with the bilateral lower limb Doppler, so we started off the treatment. And hemodynamically, the patient was not unstable, and other features were not there for us to think in terms of a pulmonary embolism at that time. Later on, although we did the complete workup.
So, I mean, somebody with a DVT, would you really think you would be low on volume? Honestly speaking,
no, sir. No, sir.
Yeah.
Not always. That's
yeah. You would actually expect the RV to be slightly bigger, IVC to be bigger.
Yes, sir. Yes, sir. Yes.
You would go otherwise. You would be.
We would usually go bigger. I was thinking more in terms of is a patient dehydrated that is worsening, the overall outcome, the overall picture. So it was a kind of a messy picture that we had initially.
Very true. Very true. I mean, it's so heartwarming to know that a cardiologist has taken charge of an intensive care. It's wonderful because you understand vasculature, cardiac physiology, vascular physiology better, and you're anyway a physician. I think it really adds another dimension. So congratulations to you.
Thank you.
Another thing, being physician is more crucial than being cardiologist while being an intensivist. What I have realized when I treat my sick patients, I think it's the knowledge of being an MD medicine what bails you out more often than being a cardiologist, especially if you have fever and if you have hypertension or tachycardia. It's very, very challenging. As a cardiologist, we have very little to do. you seek help from others. So I think in this case, what did you think many of the time, even if there is COVID, we have had instances where RT-PCRs have come repeatedly negative, but when wait for a while and do an IgM antibody, it turns out to be positive.
Yes, true.
So
we have got that.
True. There are variants which I still feel, I think there are variants which are there in the community which are not detectable with the existing kits, but they're not in so large numbers that you start phenotyping them and call something else. So I think clinical suspicion still being high, and managing him as a viral infection plus or minus COVID is still right path that you have chosen. Thank you. Dr. Kannan?
Anyway, I thank Dr. Sarthak for presenting the case. It's a good case. I think there are no queries. We can close the case.
Thank you, Dr. Sarthak. And if there are any questions, I think we should take the questions. I also don't see anything coming up here at this point. So Team Emcure, you have anything from your side? Any questions? Anything has popped up?
Dr. Deep, I think we have any questions in chat box, or you have to ask anything questions?
Yes. So so far there is no any question been observed at chat box.
Since we have another 10 minutes to go, I would really ask my two presenters. So if I have to go back to Dr. Shravan, what is your way of treating a patient who has cardiac disease plus the vascular involvement?
Definitely the heart over the leg for sure. Leg is okay, chop it off, you're still alive. But when there's no heart, you're not alive at all. So, of course, if it is a chronic limb with just claudication, no wounds, and heart disease, of course, my direct referral goes to the cardiologist once I detect there's some issues with the heart and he's not been treated for it. But when there is a wound, he's in rest pain, and something needs to be done for that critical limb, all my cases, the cardiologist is always involved. I assess the case based on whether he has requires a bypass or he requires a angioplasty like that. Of course, angioplasty, local anesthesia, the risks are less, but like my previous case, it may go on for a long time and still stimulate some cardiac events. But if it's a bypass, my cardiologist sometimes suggests either to get a CAG done or an MPI done. And based on that, it helps to stratify the risks also. And of course, we have those rare cases where we do a combined CABG with aortic bypass and all that. So of course, all cases get a clear cardiac evaluation and the family gets counseled perfectly regarding what kind of cardiac picture we are looking at. And all patients are evaluated and primed before I go ahead for any bypasses.
Fantastic. I mean, the medical management for the somewhat similar to your case, how do you manage him on a long term? Maybe after 1 month, what would be a strategy? After 1 year, what would be strategy for an antithrombotic therapy for the patient?
Yes, first 2 months I put them on full dose of anticoagulation, and like you said, taking into the bleeding risk of how much they can bleed, looking into the Hasplet scores and all that. After a couple of months, and I know the wound is on track, the vascularity is going to maintain well, then that time I step down to either 10 milligram or 2.5 milligram. I do a Doppler by myself, see the velocities and see how the flow is. If I'm happy with the flow, I switch to dual antiplatelets. And if I still need to continue anticoagulation, the only main reason would be if I had some thrombotic occlusion, some organized thrombus during the angioplasty time, or a lot of these patients have this acute on chronic ischemia kind of picture. So that time I tend to continue the anticoagulation till the wound heals, which is around 3 to 4 month period for most of our large Indian wounds. So for them, either rivaroxaban or dabigatran based on the cardiac status also. And of course, after a year and all, I completely switch to either single or dual antiplatelet. And right now, single antiplatelet of choice for me is clopidogrel. I don't put them on aspirin.
Okay. Dr. Sarthak, if
Yes.
what in your management, if you were to manage the same patient on a long term?
Sir, long term, I would definitely put him on NOAC, and that would be definitely more preferable compared to the vitamin K antagonist, at least for 3 months, and depending on the further risk factors for more than 3 months if required. So, but then we would also assess the bleeding risks with the Haspert scoring and all. Uh, Additional initial treatment, sir, we would look into the possibility where is the location. As in this case, it's a femoral, so yes, long-term treatment is indicated. And since this patient was otherwise fine, so low risk of bleeding, and yeah, so that's what I would do. And since, as I said previously, this patient is being followed up with the hematology department, they are suspecting some kind of carcinoma. So in that case, that would further increase the risk, and definitely, unless there is some bleeding happening somewhere, a long-term anticoagulation would definitely benefit the patient, sir, from a recurrent VT.
Correct. Dr. Sarthak, what I figure out is higher the risk of bleeding, I think there's also higher the risk of clotting in those people.
Yes, yes, sir.
Like
Yes, sir.
especially if there is the kind of patient that you're explaining.
Yes.
And also, if there is a triggering factor, you can probably think of discontinuing after 6 months or 1 year. And if you do the hematological coagulation pathway and find that there are no definitive coagulopathies, maybe at the end of 1 year, you can do a probably repeat CT scan and then take a call on should you continue or withdraw it completely if there is an, what do you call, instigating event such as long travels or injury.
Right.
Otherwise, what the hematological workup comes out, that would decide.
That would decide. Sir.
Coming to Dr. Shravan, what I think, this is a very typical compass case that we see in our practice.
Yes,
those who have underlying coronary artery disease, when you look at them, if you follow them at 3 years or 5 years, the risk of repeat myocardial infarction, heart failure, stroke, or a limb ischemic chances are between 20 to 50% in next 3 to 5 years. So it's not good enough that we manage the acute event effectively with intervention, but it's very, very important to treat them with appropriate antithrombotic regimen where they have the least risk of another vascular event, be it stroke, acute limb ischemia, or a myocardial infarction, or even worsening heart failure. So this was a patient whose ejection fraction is low, who's got a peripheral vascular disease. I think this is somebody who would be on a long-term 2.5 milligrams of rivaroxaban twice daily, along with probably aspirin. I know I really appreciate your concern against aspirin and preference for clopidogrel, I think, which most of us share. The GI bleed is quite common in this part of the world, and we would prefer, over an aspirin, always a clopidogrel. But the adding of the second antithrombotic regimen using 2.5 milligram twice daily of rivaroxaban would greatly protect the patient, not only against limb ischemia, but also, I think, cardiac and neurohumoral events.
Absolutely, sir. Absolutely. All my discharge summaries are big, sir. Diabetes, hypertension, IHT, severe stroke. So, like you mentioned, all vascular bits take a hit before they come to me, sir.
Absolutely. I think you'll rarely have an isolated peripheral vascular disease. I think it's a very, very rarity in today's time. So I think we all share the same thing. And that's why this platform, we learn mutually, not only the intervention. I think it was pretty similar between what you guys do, we do, or the neurologists do. But there are certain nuances that we share amongst us. And, there are certain hardware you pick up from us and certain new hardwares which are there in peripheral, which we can borrow at times.
Yes.
But more than that, I think the long-term goal, which is mainly medical management, that is where we are learning through these platforms. because without which we would be doing the same intervention on the same patients and they would be disgusted and we would be frustrated what is happening. So I think the better understanding of thrombosis, better understanding of short-term, intermediate-term and long-term clinical trial data, which is helping us to refine our non-interventional advice to the patient, especially in terms of antithrombotic regimen is a great thing. We haven't reached the pinnacle of antithrombosis, means whether 2 antiplatelets, 1 anticoagulation, or just anticoagulation, or 1 antiplatelet, 1 anticoagulation, how long? I think this was the great beginning, that combining DOAC with an antiplatelet regimen, we are learning. I think more and more clinical trials would add less bleeding, lesser ischemic events, better net clinical benefits. I think that is where the journey is going to be. And these platforms are really helping us. Dr. Kannan, if you can add anything more, it will be nice.
Am I audible?
Yes, you're audible.
Anyway, Girish, you are wonderfully compiled the session. I think I can. Thank you very much for having compiled it wonderfully. And thanks to both the presenters, Dr. Shravan and our NH guy. So anyway, the evening was very good. Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you, Dr. Damandeep. If you could take over.
Yeah. I can just say, next to Dr. Kannan sir, it was a really wonderful discussion. It was really the real life challenging cases, what we have observed in fact. And before that, sir, I would like to just put one question to you when it comes to the current situation, the COVID coagulopathies. So in terms of COVID coagulopathies, and when it comes to the usage of anticoagulant, specifically oral anticoagulant for the post-hospital discharge thromboprophylaxis. So which agent is usually preferred during your routine clinical practice? Whether it's apixaban, whether it's a rivaroxaban or something else. Dr. Girish, sir.
For me, it's always been 10 milligrams of rivaroxaban. The simplicity of using it and having sufficient practice evidence for so far, I think it's been the most preferred. Unless you have some GFR which is low, high risk bleeding, some GI bleeding risk, then probably we're looking at apixaban 2.5 milligram BID, a lower dose. If you're looking at the optimal dose, I think rivaroxaban 10 milligram once daily is still a preferred choice for me.
Noted, sir. Very well noted. So with that, my curious question, I would like to once again thank our course director, Dr. Girish sir, and moderator, Dr. Kannan sir, and both the speakers again to thank regarding their nice case presentations, which I hope really benefited most of the clinicians who are attending this particular live workshop today, and that will definitely at some point of time may help them during their routine practices. With that note, I would like to stop. But before just concluding this program, I request my team to play a quick video about the development of the molecule rivaroxaban at our R&D center. And with that 1 minute video, we will just conclude the session. Over to my team for playing the video.
Thank you.
It's not audible.
Ankit, it's not audible. Yeah, it's audible.
Presenting Emcure Pharmaceuticals. With over 500 scientists, we are pioneers in chirality. We have been making a healthy difference to countless families. With cardiology at our heart, we have strived to give you better products always. Chiral products are complex to develop. They are difficult to manufacture, but their benefits make a difference. A difference for your patients, for you. We are proud to launch our latest chiral development, Exafib, our indigenously developed rivaroxaban. Developed in-house, manufactured at our state-of-the-art facility at Jammu. This is a WHO GMP certified facility. We conduct quality checks to ensure only the best is delivered. Exafib complements our chiral cardio portfolio. Exafib, committed to make a difference in anticoagulation therapy for your patients.
Exafib is number one brand since from last 1 year, and it is all because the most of the cardiologists and clinicians they trust on Exafib, and because of its quality, where the background study or nasogastric study is very evidently equivalent to the innovator, and so that's the reason today Exafib is number one brand. So I request all the doctors to prescribe and support Exafib. Thank you, and I would like to, from behalf of Emcure, I would like to thank you so much to Dr. Girish sir for a wonderful. Really hosting the session, and thank you so much to our moderator, Dr. Kannan sir, and and also our speaker, Dr. Sarath and Dr. Shravan sir. Very wonderful case presentation, and it was really benefited to all our delegates, those who participated today. Thank you so much, and good night, sir. Thank you, Grace sir. Thank you.
Thank you. Good night, Dr. Sarthak, Dr. Shravan.
Thank you, sir.
Good night. Good night.
Thank you. Good night, all.
Good night,
Thank
sir.
you.
Thank you, sir.